Good evening and welcome to our webinar, Should I Get Prostate Cancer Screening? The topics that will be covered tonight are paramount to our community. As many as 90% of the millions of people who have an inherited mutation that causes or predisposes them to cancer are unaware of their risks. Join us in spreading awareness to your friends and family and shine the light on hereditary cancer to save lives. My name is Elise Boucher. I'm a member of the FORCE community and I will be your moderator. FORCE improves the lives of millions of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people with BRCA, ATM, PALB2, CHEK2, or other inherited gene mutations, and those diagnosed with Lynch syndrome. We accomplish the FORCE mission through our education, support, advocacy, and research efforts. No matter your inherited mutation or diagnosis, FORCE and our trained volunteers are available to help. Visit our website for expert-reviewed information and access to our support programs, including virtual Zoom meetings, our peer navigation matching program, and our online message boards. At this time, we would like to recognize our sponsors for making this programming possible and for their continued support of FORCE in the hereditary cancer community. Our presenter tonight is Dr. Paul Monk. Dr. Monk is a medical oncologist and an associate professor in the Department of Internal Medicine at The Ohio State University Comprehensive Cancer Center. Dr. Monk specializes in genitourinary cancers, which include cancers of the prostate, bladder, kidneys, and testicles. After his presentation, we will conduct a Q&A to answer the many questions that you've already sent us. We will do our best to address each one. Dr. Monk will not be providing medical advice this evening. Please reach out to your doctor if you have any other specific or urgent questions. And at this time, I'd like to turn the presentation over to Dr. Monk.
All right, good evening, and thank you for the introduction and the invitation, Elise. In the introduction, I heard 90% of individuals do not know or are not acting on their genetic information. That sounds high, but I think that probably sounds about right. So I am a medical oncologist, and I was asked to provide a disclosure slide to say, what biases might I have? But for this presentation, I didn't have any disclosures, at least from pharmaceutical sponsorship or anything like that, that I thought was relevant. But I am a medical oncologist, and I treat those individuals with genitourinary cancers. And for this talk, most relevant would be prostate. And I treat people that have advanced disease mostly. And so that is somewhat of a bias as we talk about screening. So I just want to set that up first. There are other specialties that may have a different bent toward their take on screening than someone like me that sees people with advanced, relevant, high-risk prostate cancer. So anyway, here we go. Should I undergo prostate cancer screening? And let me make sure I can advance. Well, it depends. This is a subject of great debate for the last at least 25 years that I've been on faculty. And I don't think it's really that much clearer. We should start off with definitions. So first off, cancer screening. This is looking for a cancer before cancer-associated symptoms are present. Okay, you don't want to wait till you're actually feeling the cancer or it's causing problems. When cancer may be easier to treat, and interestingly, we have to put the word may be easier to treat. It usually is easier to treat when it's smaller. The question is it helpful or not? And that's still a question sometimes. But in general, the earlier you find it, the easier it is to treat. Prostate cancer screening includes the blood test, PSA or prostate specific antigen, and digital rectal exam. There are some individuals and organizations that are wondering, the value of the digital rectal exam, but for most, that is included. Screening guidelines for those with suspected predisposition to prostate cancer and for the general risk, no. So they separated that because many feel like the recommendations should be different based on your risk for having prostate cancer. So a little bit on predisposition, maybe not much for this group, but I believe this is a mixed group that is listening in. So who should consider referral for genetic evaluation? Certainly individuals with a personal history, that is, they have cancer, certainly early onset cancer, and then for at least prostate cancer, if you have high grade disease, you should consider genetic referral. Those with first or second degree relatives, and whether or not it contributed to an early death and certain types of cancers and ancestry. National Comprehensive Cancer Network, or NCCN. This is a well-respected organization. I'm a part of this organization for testicular cancer guidelines, but they give evidence-based guidelines for the management, diagnosis, and treatment of cancers, and they have other issues such as genetics and cancer. And so NCCN will describe those that need genetic referral, at least men with family history of germline mutations, example, Lynch syndrome, BRCA1 and 2, those with strong family history, such as first degree relatives, Ashkenazi Jewish ancestry, 3 or more cancers on the same side of the family, especially if they're less than 50, personal history of, and this is where we just said, clinically relevant prostate cancer, such as locally advanced, node positive, or a Gleason score greater or equal to 7, which is also Gleason group 3. If you have intraductal or cribriform histology, it's also considered a reason to be referred for genetic referral. Excuse me. NCCN guidelines, again, for screening for prostate cancer, if found to have a genetic predisposition, then if you do, you should consider early screening, certainly for BRCA2. And early screening would be beginning at age 40. Shared decision making on risk benefits in other variants and strong family history should be considered between 40 and 45. And looking into this, this is not a unanimous recommendation, but I feel NCCN and a couple others some would agree, but again, this is not unanimous. Annual PSA and digital rectal exam. And then I put a highlight in here. There was a study, PCPT, it stands for Prostate Cancer Prevention Trial. This was published probably 12 years ago or so, 2008, 2009. And this was a study trying to prevent prostate cancer by giving individuals a drug called finasteride, a 5-alpha reductase inhibitor, an enzyme that would block the transition from testosterone to dihydrotestosterone, which is a much more impactful androgen. And the idea behind this was that if we give people this drug, we would be able to prevent prostate cancer. In this study, at the end, everyone received a biopsy, whether their PSA was high or not. And it was maybe not a surprise, but it was a revelation that men were found to have prostate cancer, not just when their PSA was 4 or higher. Some may know that we had used the term PSA 0 to 4 as normal and above 4 abnormal, but in the prostate cancer prevention trial, large study where everybody was biopsied, prostate cancer was found in every quartile, 0 to 1, 1 to 2, 2 to 3, 3 to 4, and certainly above 4, making us call into question so-called normal PSA. So that was a revelation. All right, so as I said, not all organizations agree. That's the NCCN and American Cancer Society, similar. And so that's uncomfortable. So United States Preventive Task Force, this is a highly respected organization that gives guidelines. And while some may disagree, many primary care doctors, who are the gatekeepers, kind of subscribe to their findings. And this is what they said about prostate cancer screening in those that are high risk. So USPSTF says men with family history of prostate cancer should talk to their clinicians about the potential harms and benefits of screening. And no additional guidelines for those with inherited predisposing mutations. So not quite the same. American Urologic Association, this is urology, the surgeons, their organization says those younger than 55 with higher than average risk, decisions regarding prostate cancer screening should be individualized. So not quite as strong as NCCN. American Cancer Society recommends that men have a chance to make an informed decision with their healthcare provider about whether to be screened for prostate cancer. The decision should be made after getting information about the uncertainties, risks, and potential benefits of prostate cancer screening. The discussion about screening should take place at age 50 for men with who are at average risk and are expected to live at least 10 years. Those age 45, and at high risk for developing prostate cancer, including African American ancestry, and men with first-degree relatives diagnosed less than 65 years of age. And then age 40 for men at even higher risk than that, those with more than one first-degree relative who have prostate cancer at an early age. That men at even higher risk would include those with BRCA2. So a little bit different on this. This is perhaps the best spelled out of all of them, but you can see that there's differences. And this idea of risk and benefits of screening, that's a little bit weird to a lot of people. You can understand risk and benefits of a surgery, risk and benefits of a drug, risk and benefits of screening is a little bit might not be straightforward. A common theme, though, is this idea of shared decision making. And this is perhaps not what we were doing 20, 25 years ago, and maybe even shorter than that. Here at Ohio State, and I know a lot of other places, we used to do mass prostate cancer screening, do it on a Father's Day weekend or something. We used to have 500 men come through our doors for prostate cancer screening, 500 men in 4 hours, everybody hands on deck or finger on deck, so a lot of digital rectal exams. But that was not a spot or not a space for shared decision making. It was just really man after man just coming through. And there's some subtleties in this discussion that you really couldn't do. So suffice it to say, we don't do mass screening now. We think that this is a nuanced discussion. It's not something that you can really discuss quickly. All right, so the big question is, why the differences in recommendation? Why not more forceful, clear, definitive, non-confusing recommendations? It's cancer. Why don't you just screen for it? Everybody knows you catch it early, then that's got to be right. Well, because of this, most people I know have heard this statement: most men die with prostate cancer and not from it. Doesn't sound right. Is this true or false? I know I can't hear you. I know you probably said true. The answer is true, but, and this is why it takes a nuanced discussion. So these are the cancer incidence or estimated new cases and estimated deaths for this year. This is from the journal Cancer. Prostate remains the top cancer for incidence or new cases, the most diagnosed in men. Okay. Interestingly, how breast often has close analogies to prostate. So in men, the top cancer incidence is prostate is the top, but it's not the top killer. Okay, and it's never been the top killer. Lung cancer blows prostate cancer away, and we're certainly making a lot of progress in lung cancer, but it's the #1 killer by far. So death from prostate cancer, okay, while it's not everybody that is diagnosed, it still is a relevant, serious public health issue because it's in the top 3. It's the second leading cause of cancer-related death in men. So while yes, most men may die with their prostate cancer, it's relevant cancer that we need to decrease the early mortality from. So a high prevalence of undiagnosed prostate cancer. This is one of several autopsy studies that show that prostate cancer often will cohabitate with the patient. In this bar graph, you'll see the black bars are U.S. European background, and in the gray, African American ancestry, and then white Asian. And this is the amount of cancer seen at autopsy. It didn't lead to the premature death of a man, but it was just there. And you can see it kind of gets higher as you get older. And then these little whiskers show you that there's a variety based on a number of studies. But I'll just say that, you know, when you get to your 70s, you could have 40 to 60% of men that have prostate cancer that's just sitting there, not causing the death of the man. All right, so the dark cloud over prostate cancer management is overdiagnosis and overtreatment. Okay, this is relevant from the screening of prostate cancer, so early on, all the way up to what I do is treating guys with advanced prostate cancer that they're going to die with it often, but sometimes they're not. That is, there are guys that will not die of their metastatic prostate cancer because it can sometimes move relatively slowly. Now, when it's metastatic, it's not indolent, but it can still be relatively slow. All right, so a few years back, a couple publications came out. Invasion of the prostate snatchers, no more unnecessary biopsies, radical treatment or loss of sexual potency. There's a price that you pay for taking out a prostate, and it's a price that's too high if that prostate cancer was not going to lead to your premature death. Surgery regrets. I want my prostate back. Was that really necessary? Cancer survivor nagged by doubts. So overdiagnosis and overtreatment, that's bad. Undertreatment is bad. They're both bad. Well, you would think we could figure this out with screening. And these graphs, they're coming out small, but these represent the prostate study of prostate cancer, lung, ovarian, or PCLO study on the left, showing that on the bottom graph, the lines overlap, showing that screening did not lead to any significant survival benefit versus those that were not screened. That was our American study. There were issues with this study that I won't go into, but one big issue was that the arm that was not supposed to be screened, a good proportion were screened. And this was placed in the New England Journal of Medicine. Usually when you have such contamination of an arm of a trial, that doesn't make it into publication. But anyway, the other graph is the European study. It was a much larger study, and you can kind of see that there is some separation between the control group and the screening group, and that translated essentially to screening did lead to improved mortality, and that's what matters. Okay. However, in order to achieve that improvement in mortality with screening, there was a lot of overdiagnosis, and some would say overtreatment. So that breeds confusion. Those studies were done in, I think, 2008, 2009. And then this was a few years later, comes from a study said, well, what are the attitudes for prostate-specific antigen screening among primary care physicians, the gatekeepers? How are they dealing with this? Okay. And one of the main conclusions is that less than 20% of responding primary care physicians or providers were confident in their knowledge about PSA, with a low correlation between confidence and actual knowledge. So that's if our primary care providers aren't confident, what are our lay people going to be? So with this issue, certainly with primary care docs, they need to deal with hypertension, cholesterol, colon cancer screening. There's just so much going on, let alone mental health. Primary care providers, everybody knows, have a lot on their plate. And when you have a subject that requires a nuance, takes longer to discuss, many folk will just stop screening. And then others will say, well, I'm just going to screen everyone. But that's wrong. So if you just stop screening, that's a public health disaster. Okay. If you screen everyone, I think that's a continued public health disaster. On a kind of a side issue, I'm probably talking too long here, but um, there are populations, certainly in this country, that are skeptical of healthcare. It's not just African Americans, which I am one. There's a number of people skeptical. And if folk learn that their prostate was taken out and they didn't hear that there was a potential that it was overtreated, that will set a community way back if you don't give them a nuanced discussion. So it needs to be, you need to take the time to discuss the risk and benefits of screening, because they are risk. Now, interestingly, this Dr. Cooperberg out in UCSF had a model. It said, well, what happens if folk just stop screening? Well, it eliminates all the overdiagnosed cases. So that's on the good side, but it more than doubled in his model metastatic cases at presentation. So cancer is so far spread that you can't offer a cure at that point. The model would add upwards of 50,000 excess prostate cancer deaths. Now, if you said, well, let's continue screening the way we are doing it, then you're going to have over 1 million overdiagnosed cases. And then you'll have hopefully less metastatic cases at presentation. But if you just did something that most folk think is reasonable, is maybe restrict your prostate cancer screening to individuals that are relatively old, and old being, well, maybe their life expectancy is less than 10 years. Well, if you did it that way, maybe you might have a sweet spot of a less overdiagnosis and less prostate cancer presenting in the late stages. So there are consequences either way. So one of the things that we believe is that this link between diagnosis and treatment should be broken. Overdiagnosis linked to overtreatment. I'm not going to explain this, but it showed that back when this was done, if you were diagnosed, you went and had treatment. It was almost a conveyor belt. You get diagnosed even with a low-grade prostate cancer, you were on your way to having your prostate taken out or radiated. Well, active surveillance is somewhat of a question. Well, maybe not a question. It's a way that most of us believe we can target this overdiagnosis, overtreatment issue, but also minimize those that are undertreated. All right, so the Annals of Internal Medicine had I think, a nice tool, which I think is going to be useful for lay people and primary care docs. And so I'm gonna go through this, and I think we will end soon. Key facts about prostate cancer screening and prostate cancer. So first, you want to get across to your patient that prostate cancer is common. Most men will develop it if they live long enough. Although only a small proportion of men with prostate cancer die of the disease, and I don't know if that's small, maybe 20 to 30% will die of the disease. The best evidence shows that screening reduces the risk for prostate cancer death. That's the European study. Screening detects many low-risk cancers that are indolent or slow-growing. In the United States, most low-risk cancers are treated, and the treatment itself can lead to complications such as incontinence or urinary leakage, erectile dysfunction, inability to have a satisfactory erection, and bowel problems. The prostate's in a very precarious spot. The bladder is above it, the rectum is below it. You got nerves that are going to the penis that go right by the prostate. And this is why you don't see folks that are high risk for developing prostate cancer undergoing prophylactic prostatectomies, where you may see those with the highest risk for breast cancer choosing to undergo, prophylactic mastectomies and bilateral oophorectomies to remove ovaries. The prostate, no, it's in a precarious spot. We also don't have evidence that's helpful. A few more good take-home messages for this overdiagnosis issue. The goal of screening is to find aggressive prostate cancer early and cure it before it spreads beyond the prostate. Most cancer cases found by screening do not need to be treated and can be safely managed by a program of careful monitoring called active surveillance. If you choose to be screened, there is a good chance that you will be diagnosed with low-risk cancer, and you may face pressure from your physician or family to treat it. So this, again, is suggestions on what should you tell people. And then this kind of sums it up for the guy. Discrete decision is what they called it. If you are concerned that you would be uncomfortable knowing that you have a cancer and you're not treating it, screening may not be for you. Okay, so you can understand, yeah, you're diagnosed, but they called it cancer, but they called it a low-grade cancer. Could you sleep at night with that? The other discrete decision, if you are confident that you would only accept treatment for aggressive cancer and would not be unduly worried about living with a diagnosis of low-risk cancer, you're probably a good candidate for screening. So you can see why this is not a good discussion for a primary care doc who has to deal with your 9 problems and talk about prostate cancer screening in his 10-minute visit. It's difficult. It's difficult to be a soundbite when a reporter calls and says, "Hey, can you say something about prostate cancer screening?" So, well, I need more than a soundbite. It's complicated. All right, I'm going to shift in the last 5 to 10 minutes so we can answer questions. So I know that this is a mixed group on this call, and perhaps overrepresented by folk that are certainly understanding of high risk populations, but I'm going to give you a little bit what I know about this. All right, so there are a number of germline genetic genes. Elise actually mentioned that in her introduction, but BRCA2 stands out. So this is what I'll mostly talk about. So IMPACT trial, which included BRCA1, BRCA2. IMPACT stands for the intensification of men with a genetic predisposition to prostate cancer. In BRCA2, certainly higher incidence, 19 versus 12 per 1,000 person years. I think that part of showing this was that the difference between those that are not BRCA2, it's not a whole lot. It's certainly higher, but it's not like 3 times as high. Okay, so it is higher, but it's not way higher than the average. BRCA2 is often diagnosed at a younger age, so 61 versus 64. Again, I thought that's clearly different, but again, that's not necessarily 45 or 35 versus 60, 61 versus 64. BRCA2 is more likely to have clinically significant disease, 77% versus 40% versus the non-BRCA2 carriers. Now that's a difference. Okay, so that's eye-opening. So if you are found to have prostate cancer in your BRCA2, you're more likely by a wide margin to have an aggressive prostate cancer. When you have an aggressive prostate cancer, active surveillance is not offered to you. You need to get it treated. And then the last bullet point here, some issues with this trial. Yeah, so all trials have issues. So this trial had an imbalance in compliance with biopsies. BRCA2 carriers were more compliant with their biopsies. I think I have patients that get upset with what sounds like waffling. I'm not saying it straight. Just tell me what you want me to do, doc. But often the answer is often it's not black white. There's a little gray in a lot of things in medicine. So even this trial kind of looks black and white, but there were a little bit of issue with it. Screening for BRCA2 carriers and African American ancestry. African Americans are a higher risk for developing prostate cancer and perhaps a little higher risk of clinically relevant cancer. NCCN is recommending consider initiating screening at age 40 and then consider it an annual screening rather than less frequent intervals. Here recently, there are a number of organizations that suggest, well, maybe we can screen every 2 years, every 5 years. Well, if you have this high risk, the recommendations don't do that, but do it annually. Screening recommendations for non-BRCA2 germline mutations. So that's all the others. So BRCA1, CHEK2, Lynch, shared decision making regarding screening at age 40. So that seems kind of watered down, but it was felt by NCCN, and I think American Cancer Society kind of said it as well, is that you have to talk to individuals and say, well, hey, the data is not black and white here. There is a downside for screening, and you need to hear about it. All right, well, can screening be improved for those at the highest risk? So really, BRCA2 is the main one. Can we pick out that guy and do better? Because there are folk that need, some people don't need prostate cancer treatment or screening, but some folk need maybe even more. We need help to help those at the highest risk. So MRI is a screening tool in high-risk patients. Okay, there's a study called Progress, and actually we have a link to this. Elise and Sue sent over a couple slides that we'll share about clinical trials that if you have germline genetic mutations that put you at risk, that you could participate in studies that are trying to help us learn more and maybe tailor our approaches to individuals with high risk. So this is one of them, Progress study, prostate cancer genetic risk evaluation screening study. This was reported this spring in the American Urologic Association, AUA, or urology group. This was not the final presentation. This is actually, I think, the first one from this group. 81 men, that's a bunch, 81 men with germline mutations. The highest one is BRCA2, then you see BRCA1, and the others 24%. In these individuals, their digital rectal exam was abnormal in 3%. PSA was elevated in 13%. And then the MRI was abnormal in 15% of these 81 men. All 12 patients with abnormal MRI and one with a normal MRI but a high PSA underwent a biopsy. 6 of the 13 had only abnormal MRI, PSA, and digital rectal exam normal. 8 of the 13, or 10%, were diagnosed with prostate cancer. 4 with Gleason grade group 2 or higher. That's what we consider a relevant prostate cancer. MRI did not miss any cancers, but PSA failed to detect 7 of the 8 cases. Now, that looks good. That is promising, but again, I'll say this is preliminary. This is the first data. This study is ongoing. I think the data needs to be stronger, and even the author of this study says if we weren't using MRI, it's quite possible that these patients would have their cancers eventually detected by a PSA 2 or 5 years later, and that 2 to 5 years might not be relevant for diagnosing and curing. That's why it takes longer for this study to be impactful. So a couple important points. So Gleason grade group 2 or higher, that's a relevant cancer that's found with the MRI, and that's promising because that will help us hopefully avoid the over treatment, over diagnosis, even in this high risk patient population, because even though you're high risk, you also might be high risk for over treatment because not everyone in genetic predisposition is going to die of their prostate cancer. You still got to be careful and determine if this is a relevant cancer or is it indolent. All right, and then this idea of it eventually being detected 2 to 5 years later, we don't know if this is a superior technology yet. With more time, we might know it. Dr. Solari is the PI on this study, and he went on to say, this approach with the MRI has promise, but we'll need more data and follow-up time to determine whether the MRI screening should really be the best practice in certain men. But I certainly think that patients with these germline genetic mutations warrant careful monitoring, discussion, and shared decision-making about instituting prostate cancer screening from an earlier age. Okay, and this is on the website. Okay, so if you or loved one or friend has a germline mutation, this is one study, and I think there's a second one and a third one, but again, this is on the website. Okay, I'll stop here, and I think Elise is going to jump in, I guess.
Yep, I'm right here. Thank you so much for that incredibly informative presentation, Dr. Monk. You really went through a ton of information and I think provided clarity and also really good places and resources for people to go. So as mentioned earlier, when we started the presentation, we did have some audience members who pre-submitted questions. So we're going to dive into those first. But for anybody who's attending today, if you have questions, please feel free to type them in the chat and we will address those as well. So the first question that we have, this is coming from a constituent, and I did see in one of your slides that typically screening dissipates after the age of 70. This particular constituent has a BRCA mutation, and he is wondering at what age it is recommended that he no longer needs to have prostate screening.
Yeah, okay. So age is put into screening kind of as a way of saying, well, another way of saying, well, what is the life expectancy? Okay. There are a number of guidelines that say if you're diagnosed with prostate cancer, you should do a comorbidity index. Or does a guy have heart disease, COPD, diabetes? Do you think this guy is going to live 5 to 10 years from now? Okay, so when you're 70, maybe that's 5 to 10 years. But if you come in there with your dad and he's 95, maybe not. So it seems kind of arbitrary to just say 70. I have to say I have 45-year-olds that are not as good looking as some of our 70-year-olds. And so I think 70 as just an age is black and white. That's more of a life expectancy. So I'd rather use a 5 to 10 year life expectancy. And we're not God. I am routinely wrong when people say, "Doc, how long do I have?" And I say, I'll give you a number, but I'm always wrong. So BRCA2 mutated in 70. You would think that the BRCA2 might put you at risk for early prostate cancer. It's not really early when you're 70, but if your life expectancy is, you know, greater than 10 years, you might still want to consider it.
Okay, excellent. Very thorough answer. Um, so I want to jump to another question that a constituent had. They've kind of shared a little bit of their family history with us. So he is saying that his father and his father's brother, so his uncle, both had prostate cancer. His father died of it. They both tested positive for BRCA2 mutation. This person had genetic testing, but he was negative for the mutation. He's saying that all the sites that he reads about prostate cancer talk about having a family history, which he does, but the family history seems to be due to those who carried the mutation. Would he still be considered at an increased risk, even though he himself does not have the BRCA2 mutation?
Yeah. So the answer is yes. Um, I would say you are a candidate for going for genetic counseling. So at Ohio State, where I work, we would refer you and they would go through that family history. It's surprising how much more you'll learn when the counselors kind of delve into your family. You'll A lot of families don't talk about it. Maybe your family does, but a lot don't. And then you'll start finding things, and the counselor helps out with that. And it might be more than you think in the family. But if it does turn out that there is a gene in the family, but you don't have it, that is somewhat of a relief. But family history by itself is a risk. So you might not be the highest risk, but we would consider you still higher risk if you have multiple first degree relatives.
Okay. And so there's actually another constituent question here that kind of can go along those lines. So this is from a female constituent, and she's asking, since there is incident of prostate cancer in her lineage, do her sons have a higher risk of prostate cancer? Nobody in the family has been tested, but she's wondering if she still passes down that risk to her sons, even though she's a female.
Uh, I think the answer is yes, but I think that's a little bit more of a subtle question, but I think it is related to the prior one that if you have a pretty striking family history, maybe this isn't first degree relatives, but um, multiple relatives, um, I think genetic counseling is something that should be done. Now, just a couple years ago, many organizations said everybody with prostate cancer that's somewhat high risk and other features, which turns out to be a lot of guys, should be going for genetic counseling. And then most of us said, well, we don't have enough genetic counselors for this. So I know I've had at least 3 times saying that you should go to genetic counselor. It might be that it's difficult to get into one. Um, a lot of them are doing telemedicine that might help. Um, but yes, I guess the answer is if you have a um, pretty positive, or a lot of people in the family have cancers, and you want to know what to tell your sons, then yeah, I think you need a better answer from a genetic counselor than me.
Okay. And thank you for making that recommendation and also kind of giving the varied ways in which people can connect with genetic counselors. I think it's really important for people to know that it doesn't always have to be in person, that there are virtual options, especially if they live in areas that are a bit more rural and outside of, large hospital centers. This next constituent is asking about cancer specifically and cancer growth, and they're wondering if prostate cancers are always more aggressive or more likely to be more aggressive in people with inherited mutations.
Yeah, so I did put up a slide that I thought was good on BRCA2. So BRCA2 was almost twice as likely to be um, a relevant or scary Gleason group 2 or a 7 or higher Gleason grade. So BRCA2, yes, it's often more aggressive. That's not the same case for the others, though. Okay, and so that's why most organizations talked about be careful that you have shared decision making with the other mutations. So BRCA2, yes, it does seem to be more aggressive.
Okay. And speaking about, you know, different types of cancers and different types of mutations being more aggressive. This one constituent is saying there's only late onset of prostate cancer in his family, but both his older brother and his father were diagnosed, but both over the age of 60. His father being diagnosed at 82 and his brother being diagnosed at exactly 60. He himself is 59. So he's wondering at what age should he start to do screening and how long should he continue it if he hasn't started already?
Yeah, so at age 59, I think that the discussion, the shared decision making of risk benefits of screening, that article that is toward primary care docs saying that the the risk of screening is that you are now diagnosed and now you have a so-called low-grade tumor. So now you have cancer, but they call it low grade. Could you sleep with that? Are you gonna be up at night worried if you're told, it happens, and we're still taking prostates out that are, only have low-grade tumor, but there's a cost for that with potency, urinary leakage. So the general question, yeah, I got some family history, and so yeah, we do, think that shared decision for screening should be considered, and that means you have to consider a bunch of things. And so I guess at 59, with family history, you need to hear about the pluses and minuses of screening.
Okay, excellent. Well, that wraps all of the questions that were submitted for the presentation. So thank you so much, Dr. Monk, for your time. Like I said, incredibly informative presentation. For everybody who's on tonight, this of course is being recorded and the presentation will be uploaded to our webinar main page in the next couple of days. So you will have this presentation to go back to review Dr. Monk's slides. But thank you so much, Dr. Monk, and we are very appreciative of your time and expertise.
Yeah, thank you.
Okay, and at this time, we are just going to close out and thank you for joining. And then again, we just want to thank our sponsors again for helping to bring this programming to you. Please continue to reach out to FORCE for your support and information needs. While there are many mutations and many cancers, there is just one community, the FORCE community, that supports anyone who is impacted by them. Thank you again for attending, and good night, everyone.